Good. All right. Well, good morning, good afternoon, good evening, wherever you are. Welcome again to the Innovations in Healthcare COVID-19 Learning and Action Network call. Thanks for joining us. Welcome to our innovators, our gig grantees, and all of our guests. We have a great program lined up today. Give me a second for my slides to advance. We're going to start off today with a panel, maintaining maternal and child care during the pandemic. We're going to have each of our panelists introduce themselves and give a brief introduction, then we'll have a Q&A session. We certainly hope that you will join in that discussion. After the panel, we're gonna do our solutions, insights, and lessons learned from our innovators today. Joining us are Maternity Foundation and WeCare Solar. So just general guidelines: keep your mic muted. I'm going to ask today that for non-panelists, we're turning the video off when not participating, so we can see the panelists. Please participate. This is a facilitated discussion. You are the experts. We want to hear what your experience is on the ground, what solutions you've seen. Please join in by voice or by chat. You can raise your hand to speak on the participants panel or chat at any time. This session is being recorded and will be posted in the call topic groups on Groups.io. And please keep this conversation going on the listserv on Groups.io. If you don't get your question in, please post it then. If you started an interesting conversation, please continue it. So, without further ado, I'd like to introduce our panel today. First off is Diana Silimperi. She's a visiting professor at the Duke Global Health Institute, and she's with us here at IH. She has 30 years of experience in global health. She's going to be giving opening remarks. Following Diana will be Sawan Shah, the CEO of Jacaranda Maternity Hospital, Rodgers, the executive director of Lwala Community Alliance, Chole McDonald, a senior portfolio manager for Grand Challenges Canada, and Scott Higgins, director of operations for Merck for Mothers. So without further ado, Diana, could you lead us off?
Happy to. Good to be with everybody today. Instead of my 5-minute research update, I'm going to do a 5-minute pre-panel. Some thoughts for you all. Looking at a quick overview of several scenarios that have been developed by researchers around predictions of increased mortality as health services for routine, sort of essential care is declining. These are often what we consider preventive services, or as I heard from our introducer there, Jed, that it will particularly focus on vulnerable women, pregnant women, and newborns and children. So obviously we all know that the pandemic is adding pressure to already overburdened both social services, but specifically health delivery systems across the world, and including obviously low and middle income countries. That's exponentially so in the fragile states that I'll mention, or those with humanitarian crises. What you may not realize is that it's more than likely resulting in millions of deaths that are preventable or that have routine treatments available during normal times, particularly in children and women. In some cases, as we saw with Ebola, there may be more deaths in areas resulting from these routine causes that are normally treatable than by the virus itself. So while countries attempt to control and interrupt the spread of the virus, take care of those people who are so ill with COVID-19, resources, including personnel, sometimes supplies, equipment, pharmaceuticals, are shifted often to hospitals or to the hotspots where many people are sick. Personnel are also decreasing because of their own illness or needing to care for their families. But we see typically a shifting of personnel from, again, preventive care services, often primary health care, and family planning, for example, into the hospital care. Obviously, supply chain disruptions and failure of supply chains are hitting, again, across the board, but specifically some of these types of facilities. Some of them are closed. We're seeing closure of primary healthcare facilities and or services, particularly those in these areas of maternal, newborn, child health and sexual reproductive health, are either markedly decreased or ceased during this period. Furthermore, as you know, people are frightened. They're afraid. They're often afraid to bring their children if they're sick, or a pregnant woman is afraid to seek services during this period of time. And that doesn't even begin to look at the issue of mobility restrictions, the lack of transport, border closures, and so forth, or the financial difficulties from lack of employment that are limiting people's ability to receive or to seek routine care. So what does that mean as these services get shifted to protect some services around COVID, but in fact discontinue or minimize capacity in others? Researchers at Johns Hopkins recently published in the Lancet the indirect effects of the coronavirus on maternal, newborn, child health in low and middle income countries, over 118 countries. They modeled 3 different scenarios in which coverage of these routine interventions are reduced by 10 to 50%, and for different periods of time, 3, 6, and 12 months, using assumptions emerging from real-time supply side and demand side effects of the pandemic. And they used, as many of you know, the LIST or the LiveSave tool to model maternal and under 5 mortality. I'm going to just go through a few of their findings. And they predict that reductions in coverage of 15% for 6 months could result in over 253,000 additional child deaths and over 12,000 maternal deaths. I'm rounding off. Reductions of 45% for 6 months would result in 1,157,000 additional child deaths and 56,700 additional maternal deaths, which were huge increases in under 5 deaths per month and maternal deaths per month that you would expect in these 118 countries examined. Those at Guttmacher looked at 132 low and middle income countries, and they estimated with a 10% decline in the use of short and long-term reversible contraceptives. That would bring 48,558,000 additional women to the point of unmet need for modern contraception. A 10% decline in service coverage of pregnancy-related and newborn care would impact over 1,700,000 additional women experiencing major obstetric complications without care, which would result in 28,000 additional maternal deaths and 168,000 additional newborn deaths. They also looked at the shift from safe to unsafe abortions, which could result in an additional 1,000 additional maternal deaths. And both WorldVision and International Rescue Committee have looked at the impact of the decrease of routine essential care for maternal newborn child health in high risk, so-called fragile states, those with under humanitarian crises, 24 some countries, and they estimated as many as 30 million people are at risk from what they call secondary health impacts. They modeled really based on Ebola, their previous studies with Ebola, and they found that 26 million children are at greater risk of exposure to fatal infectious diseases because of the decrease in DPT-3 coverage. More than 5 million additional children would suffer from malnutrition, so these obviously have long-term effects, including severe wasting, which is an increase of 40% from the current numbers in those already high-risk countries, and 100,000 additional children could die from malaria in those 24 countries, which is an increase of over 50% from current levels. So the numbers are quite sobering of the particularly mothers and children under 5 and newborns who could be impacted by this pandemic because of the lack of routine care. Let's turn it over to the panel and see what you're finding and what we're doing to address that among our partners here. Over to you, Jed. Judd? Hello?
Sorry, Diana. Had a problem with my microphone. Thank you so much for that introduction. And now we are going to turn to our panelists. Thank you again and welcome. First up is Sawan Shah, the CEO of Jacaranda Maternity Hospital. Sawan, I'm going to ask Sawan and Ash to tell us about the experience. First, introduce yourselves and your organization, and give us an idea of what your experience on the ground is and your ability to maintain routine care for mothers and children. And then we'll hear from Chole and Scott. Would love to hear from them. Obviously introduce themselves and their organizations, and like to see what you guys are seeing and how are your organizations responding. So with that, Sawan, are you there? And I guess I can share your slides if that makes sense.
Yeah, that'll be great, John. Can you hear me?
Yes, I can hear you.
Super.
Give me 1 second. I will try and find slides. There we go.
Great.
Right ahead.
Thanks so much. Well, hi everybody. My name is Sawan Shah. I'm the CEO of Jacaranda Maternity Hospital, which is a for-profit social enterprise. We currently have one maternity hospital in a peri-urban region northeast of Nairobi, and we currently serve mainly a low-income population. Although we kind of our business model sort of focuses on a mixture of lower middle income as well as lower income populations. We're very much a primary care maternity service driven provider. And our mission is transformational, high quality, low cost and respectful maternity healthcare with our vision to become the largest chain of hospitals with a focus on maternal and child health in the whole of East Africa, providing high quality care at affordable prices. So, without much further ado, I think, Judd, if you could move to the third slide. That'd be great. Yeah, and it's important to set the scene for those who don't know what's happened in Kenya. Essentially, I think it was probably the third week of March when we first found ourselves with the first COVID case. And I remember it was an interesting one because I was actually on the search for our second maternity hospital location, and I was sitting with a cab driver, and we suddenly heard the information on the radio. And as soon as that happened, the government's response was pretty immediate and fairly drastic. Schools were effectively closed, restaurants and many sort of public gathering areas were pretty much shut down. Shortly, a few weeks later, blockades commenced as more and more hotspots of, particularly within Nairobi, were identified, and in a bid for further counties to avoid getting overdue infections and people actually moving to other counties. The government, in effect, shut that down by creating these random blockades in different locations in different counties where different counties were meeting. And the government also put in effect a nighttime lockdown, which meant that there was a curfew and nobody could venture outside of their houses or their places of accommodation, apart from those in essential services. And as the sort of the situation has developed, what the government has done in a bid to try and keep businesses going in as much as possible, but also identify and restrict hotspots, is that they've gone towards really, really high hotspots or red hotspot areas where more and more frequency of COVID cases have been tested and positive cases have resulted, and actually created a mini lockdown in effect, preventing people from moving out of there or coming into there. So, I'd like to talk about what's happened at Jacaranda, and I have to caveat that everything that we've experienced is probably, our own immediate response and may not be a representation of what's happened out there. And what we've done has been a very, very personal response. Certainly, as soon as things went haywire with regards to the first COVID case, we ourselves admittedly experienced a lot of pushback from our healthcare workers, where there was a lot of fear and sort of foreboding about what to anticipate next. And that could be a natural sort of occurrence. And it was important from management's perspective to remain a little bit level-headed about how to tackle the situation. And, the first focal point that we had, given that we are a social enterprise and that our business is very much driven through services being rendered, is that we started thinking about the operational response, which is actually number 2 on the list, and apologies about that. We tried to ensure that those who could work from home, and the first thing we started doing was try and reorganize workflows in order to create a social distancing for our patients. Our maternity at the best of times is super overcrowded, experiences a high volume of human traffic coming through. And so it was really, really important to be able to create the space that unfortunately we didn't really have initially. And that saw a combination of some smart thinking and, primarily a bit of luck by being able to create the space and setting up spaces outside where we thought, hey, you know what, let's just put some chairs outside, create the social distance, and then our midwives and our staff will call the patients to come in, because this is the way it's going to have to be if we're going to make sure our staff remain safe. We started pushing on creating appointments, a whole bunch of appointments through virtually creating an online system. And that was really, really important because it's a very Kenyan mentality to turn up to a prenatal clinic at the same time. The majority of our patients turn up to their clinics at about 10 a.m. or 11 a.m. And that high level and surge of traffic was something that we just could not maintain in the current environment. So we started pushing the importance of having these online appointments being booked. And along with that, we started screening everybody from the get-go. So making sure that there was enough, that people were actually coming in and getting screened with temperature gauges for what it's worth, making sure that people coming in had masks, and we ourselves had enough PPE to be able to sort of work around the situation. The final piece was just, from a managerial perspective, was more to do with just constantly keeping the encouragement up and ensuring that to sort of reassure our health workers that we had enough PPE to be able to take care of the situation and protect our healthcare workers as much as possible. That management was doing enough in terms of trying to create the social distancing and ensuring that people felt like we were actively trying to look after them as much as possible. It also led to a certain number of questions, especially as the 7 p.m. curfew came into play, about how our shifts could actually be done, considering we're a 24-hour facility. So we started introducing some smart solutions, like providing overtime to those evening workers to actually turn up to work an hour earlier. I mean, all of this would be an extra cost to the organization, but at that point in time, it seemed like this smart solution so that people could actually go home and get home before the curfew hours actually begun. And in addition to that, we introduced, for what it's worth, a travel stipend just to accommodate people because the public transport system started hiking up their prices to take into account the reduced number of people that were allowed onto buses and matatus at any given one point in time. The final piece on the operational response was it was important that our clients were actively engaged and understood what we were trying to do. So we really pushed hard on social media and outdoor advertising to make sure they understood the importance of wearing masks, of hand washing when they came in, and that these sort of measures were not being put in place for any other reason than to protect themselves. So that was from an operational response point. On the clinical response side, what we started doing was we have a bunch of investors that are institutional investors from all around the world. So we tried to tap into that sort of level of capacity in order to understand how best to work our protocols. And we did that through interactions with a variety of Japanese maternity hospitals, and as well as working through WHO clinical best practices in order to rework our maternity and labor interactions. Now, a lot of this is work in progress, so a lot of this is still moving and flowing and changing and evolving as we speak. So, it's kind of a very iterative process as we ourselves learn and try and figure out how best to improve ourselves, etc. In addition to that, there was a blanket statement that was put out by my doctor in charge to ensure that even if there was a COVID patient that came in, that it wasn't an urgent response that was needed. You didn't need like 20 people running towards that particular person in order to help them. That the importance of protecting the health worker came first, and then the need to serve that particular patient came second. We also reduced the number of visitation rights dramatically in order to just ensure that we weren't, having any sort of additional exposure than absolutely required. And this is sort of contentious. Some people believe that visitation rights should continue, but we just took a stance that it was better not to have extra visitors because we needed to decongest our maternity. On the finance side, which I think it's really important to touch base on, we learned very quickly the importance of trying to reduce the level of cash flowing out. And what we started doing was scenario planning from a very, very early stage in order to feel out what would happen if our outpatient numbers reduced, because there would be this dramatic fear of hospitals not being COVID hotspots, so to speak. We did that, and at the same time, what we also anticipated, which is correct, is that we were going to get fewer private insurance companies and public insurance companies actually paying us on time, and that there was going to be a higher cost associated with the amount of PPE and the increased amount of focus on sanitation. So we began managing our creditors and having these discussions from very, very early on, and really reducing the level of cash that we were spending apart from what was absolutely necessary. So, for example, finance costs, we had the negotiations with our financiers in order to stop interest and principal repayments. We also increased our spread of suppliers because supply chain was absolutely insane when the first COVID case was announced. There were just too many suppliers. It was honestly like cowboy territory, because every single person was offering masks, but at dramatically different prices. And then when you locked in a supplier, you'd find that the lead time was just unsustainable for us. So we really tried to spread our suppliers, go out and really look for suppliers wide and far in order to know that we could, at very, very short notice, change suppliers and that we would be okay. We were also tremendously lucky. We actually had negotiations with all our investors who then came through and provided us with additional grant funding in order to protect our primary care workers, as well as introduce new avenues such as telehealth and teleconsultations, which is something that we were really looking at as a new business driver. And finally, what we did on the finance side was there was some open-ended Series A deals that we were yet to close on. We made sure that we closed them as soon as possible. We did that because there's going to be great uncertainty about fundraising in the near future and probably for the next 1 or 2 years. And we wanted to make sure we had enough cash on the horizon should we need to tap into it. And then finally, very, very quickly, there's the strategic response that is really, really important. How as a maternity hospital, as a standalone maternity hospital, do we look at this and seek out opportunities and act in a very, very fluid manner? We have introduced telehealth as one of our potential business drivers, but more importantly is given that our market isn't particularly interested in telehealth consultations, we've introduced pharmaceutical deliveries, which is working pretty well. And we also came up with a bunch of partnerships with, for example, Little cabs. And for those who don't know Little, it's the equivalent of Uber, which is, and essentially we partnered with them in order to offer free passage for patients experiencing labor pains at night so that they can make their way to our hospital in a safe manner. Finally, on the expansion, what we've actively done is realize that the amount of expenditure that we had anticipated to go into the next few maternities is now going to dramatically be reduced in terms of CapEx. And we're doing that because we wanted to have an eye on our runway to make sure that there is enough cash that can sustain us for the immediate future. It's made us think long and hard about how much cash is actually required in order to build out a maternity hospital. And none of these questions I have the answer for right now, but it's certainly making sure that we push more on our supply chain levers in order to extract more value from contractors, from equipment providers, and really ask the harder questions that we may not necessarily have asked ourselves, or we certainly may not have asked ourselves very push those pressure points as much as we are doing now. And whilst we do want to expand, we're taking it with a lot more caution as we see the demand for maternity, which continues to grow, start to shift in terms of willingness to pay. And as a consequence, we need to reanalyze which locations we actually want to end up setting up as with. So that in a nutshell is what we've been doing. Hope that's
Thank you for your overview. I want to give our other panelists a chance to introduce themselves and tell us about their situation. I'm sure we'll have some follow-up questions for you and the other panelists. Give me 1 second here. Ash, do you have any slides to share, or are you going to?
Yes, I'm going to try to share my screen here. Yeah, let's see how this works. Can you see my screen well? Are you seeing just the presenter view, or are you seeing the slides?
I'm seeing the presenter's view right now.
Shoot, I thought that might be the case. Okay, let me try this a different way. How about now?
Give us a second.
What are we seeing here?
Just the presenter. I had the slides before.
Sorry, guys. Shouldn't be so hard, should it?
There we go. That's it.
There we go.
Okay, and you're seeing just the slide?
We can see the preview on the left, but that's fine. Mm.
Okay. Well, I'm just going to start so we don't spend all of our time figuring out how to get the slides perfect. But you can see I'm guessing at least what I'm seeing. So that should be fine. All right. So my name is Ash Rodgers from Lwala Community Alliance. We work in Western Kenya in a county called Migori. And then we're also working at the national level around COVID response and particularly around policy. Lwala Community Alliance, we are a community-led health organization and have 4 pillars, which is community committees, through which we work with community units and health facility management committees, which are both official structures in Kenya. And we work with them to be part of the quality improvement process at both the community level and the health facility level. We work with community health workers. We recruit first from all active traditional birth attendants in the region, and then combine them with government cadres of community health volunteers. We support them to be paid, trained, supervised, and equipped with technology. And then we also work at primary health facilities through a quality improvement process that starts with that health facility management committee and is about organizing both the clinical staff and the community to identify needs at the health facility, and then work and plan, do, study, act processes to tackle those challenges. And then our 4th pillar is data. We have a mobile app that's built off of ComCare from Zamagi, and that our community health workers deploy that gives us individualized data across the communities that we serve. And in addition, we do repetitive population level household surveys. Our COVID-19 response, we are really orienting our response around 4 key pillars. The first is to protect health workers. The second is to interrupt the spread of the virus. The third is to maintain essential health services while surging the health system's capacity. And the 4th is to shield the most vulnerable from socioeconomic shocks, which we believe to be an equal public health crisis. Today, I'm going to just focus on that 3rd piece, which is around maintaining essential health services. In order to do this, we have a few interventions that we're focused on. The first is PPE for all. In Kenya, but really across sub-Saharan Africa, there's many ministries of health and national governments that aren't including the community health workforce in their PPE calculations. Obviously, this is problematic. If we want community health workers, and indeed we do want community health workers to be part of this response, in every country that has been able to stem the spread of this virus and make a turn has done so by community level contact tracing and contact monitoring. So clearly community health workers are an essential part of this solution when it just comes to interrupting the virus. And then we all know that as the health systems are continually strained and there's stress on the health facility, the community health workers provide a great opportunity to provide primary health services without overcrowding health facilities. However, we need to protect them like any other cadre. And so we're pushing for PPE for everyone, and that the level of PPE should be based on the task, the medical task that you're performing, rather than what cadre you are in the health system. And so if you're doing an aerosolizing procedure, you should have more advanced PPE. If you are doing more routine procedures, you should have a mask, you should have a gown, you should have gloves. And so we're equipping all of our community health workers with that PPE. We're supporting at the county level in Migori, supporting some of the gaps in PPE for other health cadres across the county, and then obviously working with other partners because we can't supply all of that PPE on our own. So we're helping to coordinate response. And then we're doing pooled procurements with other community health organizations to get supplies in. And there's some movement around the development of local supply chains for a lot of this PPE. So that's a bright spot in Kenya. We're working on a revised, we have developed a revised community health worker protocol. If anyone hasn't seen yet, the UNICEF came out with their revised ICCM protocol that has approval from the WHO. We think it's fantastic. Our protocol is built upon that. And then we're developing digital tools to support community health workers to continue to provide routine services in the midst of this virus. And that includes a self-check tool where the community health worker is doing a self-check before they go out, and then a COVID screening tool that's done over the phone before they're actually deployed to households. We're particularly concerned about malaria testing and treatment and really want to make sure that malaria testing and treatment can continue. Obviously, that's a big opportunity for increased deaths if we aren't able to provide malaria testing and treatment, particularly to the most vulnerable populations. And then our community health workers are also now delivering pharmaceuticals for folks who are HIV positive and folks with other chronic illnesses that are otherwise well managed to reduce the number of visits that they need to do, the repeat visits. And then we're separately training a cadre of what we're calling CRCHWs, which are COVID response community health workers, and they will be tasked with contact tracing and contact monitoring. And then at the village level, we're doing village level open air outreaches that practice social distancing and infection control. We really had to work with the ministry on getting everyone comfortable around this idea, but we think it's really important. And because of those open air well patient outreaches, we're able to provide family planning, to provide immunizations, to provide ANC services without funneling all of those otherwise healthy patients into health facilities. And those have been working fairly well. And then we also have mass communication. So we have a radio program and bulk SMS that are focused particularly on COVID messaging and hand hygiene, but also child protection and sexual and reproductive health messaging. And then we're leveraging existing WASH interventions. So encouraging the creation of hand washing stations, distributing water treatment solutions, and supporting the local production and distribution of soaps. So that's what Lwala is doing. I also want to give a shout out to the Community Health Impact Coalition, which is a coalition that we're part of other community health practitioners. And we've been working out a lot of these logistical challenges with that Community Health Impact Coalition. And we've published 3 different papers over the last several weeks around our positions of the community health implementation in the time of COVID.
Great. Thank you, Ash, for that overview. Sounds like it's been a pretty comprehensive response. I would like to go over to Chloe now. She's the Senior Portfolio Manager with Grand Challenges Canada. And I'd like to ask sort of, what are you seeing in your portfolio, and how are you as an organization responding?
Yeah, thanks. I don't have slides, but I'm very excited to be here, and I really enjoyed hearing those previous discussions around what innovators are doing, because we're obviously a funding organization supported by Global Affairs Canada. So we're trying to deploy funding right now, as well as support our existing portfolio of innovations. Our approach has sort of been twofold, where first of all, we're trying to adjust existing grant agreements or loans in ways that support our innovators as they're handling COVID-19 in their implementation settings. So often those are, if it's a no-cost extension, if it's delay on a repayable in some cases, just ways that our existing agreements can be adapted so they're best supporting innovators at this time. And then our second sort of strategy has been to try to deploy additional funding to support innovators in our existing portfolio to start with as they move towards responding to COVID. So Our existing portfolio exists entirely of innovations that are focused on maternal, neonatal, and child health in resource-constrained settings and ways that save and improve lives. So we already had an existing portfolio full of these really incredible innovators that were responding really rapidly to the outbreak of COVID-19 in resource-constrained settings with a focus on sexual and reproductive health and rights and maternal and child health. So we started to deploy additional funding in a first case focused on personal protective equipment, oxygen access, and digital health tools that promoted patient connectivity and combated misinformation. And then a second deployment of funds that really focused on primary healthcare and ensuring access to ongoing essential services in the settings where our innovators are already working. We are looking at the possibility of taking on new investments as well, but our strategy on using our existing portfolio is to support the innovators where we already have that relationship in place, and it allows us to deploy funds much more rapidly because you don't have to go through the due diligence process to bring those new deals in, but that's something that we might do in the future. Right now, I would say a lot of the investments that we're making in the primary healthcare space or hoping to make in the near future are probably, the money is probably going half towards retooling in terms of getting more PPE in place and allowing innovators to have infection prevention control measures and the supplies that they need to do that. And then the additional funding going towards training and ensuring that the healthcare providers and community healthcare workers in their portfolios are adequately trained on in terms of their response in light of COVID, as well as providing education to their patients and community members in terms of how to maintain access to care in the context of COVID-19, as well as some adaptations to service delivery, as you know, both of the previous panelists spoke to in terms of bringing things that can be brought online, and or some systems changes to prevent too many patients from coming in at the same time, or putting infection prevention and control measures in place. Yeah, I think that's sort of a high-level summary of where we're at right now, but we really see our role as just trying to get funding out the door where we can to support innovators and their responses in light of what's going on, as well as creating strategic partnerships where we can, particularly interested in connecting people with the demand side in terms of WHO partners and in-country government partners. Where we can, that's been a huge priority for us. If we can find demand side interest from our public partners for uptake of a lot of these systems, services, and innovations, that's something that we're very interested in doing when we can do that for our existing portfolio of innovators.
Great. Thank you, Chloe. I'd like to give Scott a chance to introduce himself and Merck from others, and we'll maybe have a time for a question or two for the panel. Scott?
Great. Thanks for inviting us to the panel, and appreciate the opportunity to talk with you all. For those of you who don't know Merck from Others, we're a $500 million initiative within the global healthcare company. And since we've launched Merck from Others, we've reached over 11 million women in 48 different countries, and we're focused on ensuring that when a woman receives, when a woman goes for quality, when a woman goes for maternal health care, that she receives quality of care, regardless of where she seeks it. In response to COVID, we've recently announced some funds set aside explicitly to address COVID challenges that have impacted a lot of the healthcare system. Since the beginning of the pandemic, we've really been spending a lot of our time listening to the partners that we fund, listening to frontline workers, talking with other funders and co-funders who are working in this space, and most importantly, listening to women. Some of the things that we're hearing are related to challenges that women are facing when seeking healthcare. It's around finances, access to transportation, and just general fear about the healthcare system and seeking care there. As we all know, childbirth isn't going to wait for the pandemic to clear, so addressing those things in real time is important to us. Some of the things that we're hearing from our partners is, first of all, that they're really stepping up in a flexible way around response to the COVID pandemic, and really around three key areas. One is around filling an information void. A lot of our partners are seeking to address the lack of good quality information about COVID, about the care and treatment of patients exposed to COVID. So a number of our partners have set up virtual resource hubs, pivoting their training around infection control, creating learning platforms for themselves as well as their peers, and kind of doing some myth busting around COVID. The second thing that we're hearing is around innovation and flexibility. And there are a lot of good examples, which I won't go through now, but maybe we can have some discussion about them later. But creative approaches to how care is delivered, how information is shared. Some of the points raised earlier around the challenges around access to technology and other equity-related elements. Some creative approaches, not only here, not only in the developing world, but here in the United States as well. And the third area is around managing with resource constraints, and some creative approaches to standardizing protocols across multiple facilities, including in the private sector, in some cases with competitors. There's some evidence in some countries where we have government reaching out to private sector facilities to accelerate access to maternity care through integrating of private care facilities into the government healthcare provision. And also looking, one of the things that we heard from Sawan as well is, this is forcing people to look at their capacity, the limited capacity that they have, and creating focus, which then drives a more rigorous review of what's the most important elements to focus on, and ultimately that can help sustainability, especially of private care facilities. So in summary, we're continuing to listen. We're looking for ways of encouraging flexibility of our partners, and we're demonstrating openness to innovation and looking for creative ways to solve some of these problems. I think if we do this right, we'll ultimately end up stronger in the places that have been broken by this. So we're really hopeful that a lot of these lessons learned and these innovations ultimately become a place where these innovations become best practices that can be shared across multiple entities. So thanks for the time today.
Great. Thank you, Scott, and thank you again to all of our panelists for participating and sharing their experience. I think we've had learned a lot of lessons and had a great survey of the landscape in maintaining care for maternal and child care. Maybe I can ask the audience if they have any questions to chime in or add it into the chat, but maybe I want to pick up on that thread, Scott, that you said that you had there as far as innovations. Are there, to all the panelists, are there any particular innovations that you would like to highlight, that you have seen that you'd like to share, I guess, with the audience that are of particular note?
I think maybe just to say that this pandemic highlights the importance of strong health systems, and particularly strong community health systems, and the reason that we need to have broad-based investment in health systems all the time. we've been working on with UNICEF and USAID and this Community Health Impact Coalition on the AIM tool, which predates this pandemic, but really outlines design principles for the deployment of community health workers. And we find that those design principles, which are the community health workers should be paid, they should be equipped, they should have a dedicated supervisor, those key principles, while not exciting innovations, not done globally, but when they are done, all of our health systems can be a lot stronger. And it's particularly true right now. And we're finding that in places that have strong community health systems are much more ready to respond to this outbreak.
Thank you, Ash.
Yeah, on our side, I think what is actually brought to light is the ability to really work well under resource constrained settings. The interesting piece is that as we've grown and evolved and been focused on our business model, one of the areas that we've always looked at is how do we reduce costs, and at the same time, what COVID has definitely brought back to light is the very fact that there's a reliance on PPE that's more pronounced than ever before. So as you're working towards trying to make sure that your unit economics are up to scale, and at the same time providing a safe work environment for your health workers, there's been all manner of changes in terms of very, very small but interesting innovations that have taken place within our small facility that has actually led to both a reduction in costs as well as innovation that's actually kept our healthcare workers safe. Obviously, there's still a lot more time that for this pandemic to evolve, but I foresee that there's going to be an increasing focus on should our supply chain break down completely, which I hope it doesn't, how we actually utilize the existing resources we have, and then actually come up with solutions that are more homegrown than ever before. And that's something that I feel that at least our team is very, very well equipped to actually do.
Yeah, along the same lines around supply chain, we fund a network of small private healthcare facilities in Nigeria. And when the pandemic broke out, they recognized that supplies were going to be an issue. And one of the things that they did was they started to pool demand for these critical supplies, including family planning products, across the network. So these were, individual facilities that previously hadn't been strongly linked to each other, but by pooling their demand, they avoided the situation where one was stealing supplies from the other, and it became a more collaborative supply chain, and frankly gave them more power in terms of pricing and quantity, which I think was a creative and innovative approach. A couple of the other things around access to information is one of our partners is looking at providing voice recorded guidelines for mothers, recorded in the local language, so that they can dial up and use and access voice recordings that provide them guidance that would help them in their childbirth process. And similarly, and this is in the U.S., we're looking at a way of delivering virtual postpartum care for those who have difficulty or are challenged in terms of accessing care, and looking at ways that we can do that virtually and make that more accessible. I think another area that is a huge opportunity is in some of the digital health innovations and looking at access to information that's being provided through chatbots and other technology, a way of tapping into fears and concerns of mothers during this time, where they may be concerned about family planning, but are also asking questions around COVID, infection control, and things like that, and using digital technology as a way of kind of alleviating some of those fears. So, I mean, those are just a few quick examples around innovation that I think are kind of emerging at this point.
Well, thank you. I'm afraid we're at the end of the time. I would encourage everyone to maybe continue this conversation online on our chat board. But I want to take this time again to thank our panelists for joining us. We do have two more speakers for those that can stay past. We have Maternity Foundation talking about their safe delivery app, and WeCare Solar is going to talk about their technology very quickly. But once again, thank you very much to our panelists. And please, we'll continue this discussion online. Okay, with that, I'd like to introduce Tara Telavacchia with Maternity Foundation. Tara, you still with us?
I am. I'm here, and I'll be really brief because I know we're almost at time. Let me pull up my PowerPoint. I'm having the same problem as Ash. It's not letting me go into presentation mode. That's okay. For the sake of time, I'll do the same thing she did. Can you at least see the general part of my screen? Great. So I'm not going to go into what the Safe Delivery app is in detail because I presented on it back in March, and also we don't have a whole lot of time, but really briefly, the Safe Delivery app is a job aid and a training and learning tool for skilled birth attendants, and it primarily focuses on emergencies that arise during childbirth, how to identify, prevent, and handle and refer these. What we've done around COVID, there's kind of two main things that we are working on. Last month, we were able to pretty rapidly create and publish a video on infection prevention specific to skilled birth attendants during COVID-19 in French and English. And then we took this video together with a whole bunch of other content and added a new module on the Safe Delivery app that's specifically focused on how to keep yourself as a healthcare worker, as a skilled birth attendant, safe and protected during this pandemic, how to minimize the spread, how to identify symptoms of COVID-19, answering some of the main questions and concerns that skilled birth attendants have right now, including support around breastfeeding and how to ensure good hand hygiene, all of those kinds of things, while continuing to provide quality care during COVID-19 and respectful maternity care, which is as important now as it's ever been. So that's one of the things that we're doing. And we're constantly, this is WHO aligned content, we're constantly updating it, which is one of the fabulous things about digital. As new evidence emerges and guidelines are updated, we can push them out in real time. And two examples, we're adding more PPE content, and we're adding UNFPA's developed a bunch of guidelines on ANC and PNC that we're publishing on here as well. And this has been a collaborative process with Laerdal Global Health, University of Copenhagen, ICM, UNFPA, with support from Merck, from others. And then the second thing we're doing is we're working on a remote training concept, because the Safe Delivery app is really strong on its own, but it's even stronger if accompanied by a remote training concept that can ensure that skilled birth attendants are provided a pretty rapid but thorough introduction on how to use the app, where this content is, and going through it in a way that is more interactive. So we have master trainers in a variety of different countries, including Ethiopia and India, who are pretty good at engaging skilled birth attendants both at universities, so pre-service, and then also in service and refresher training with all different kinds of training methodologies. And then, so they're working to take those training methodologies, whether it's digital breakout rooms or self-study time or polls and quizzes, remote simulation, which is something Laerdal Global Health is really good on, digitizing all of that and deploying it in a few settings, but beginning in 100 quarantine centers in Ethiopia. So that's my super brief overview of what we're doing. If you want to hear more, please reach out. I'm happy to share more. And the app is available for free to download on Android and app in the App Store.
Great. Thank you, Tara, for that overview. We will certainly post your contact information in reply to this posting, and certainly you can provide more information through our LAN. That would be great. Next up is Laura Satchel with WeCare Solar.
Thank you. Let's see if we have the same problem. Okay, well, thanks very much. I think following on the tail of all of the discussion about the need for essential services and the concerns about increased maternal mortality, WeCare Solar is really focusing on energy access for maternal health care. And I think as concerning as care is for anybody who's working during COVID-19, it's really important to also remember that many facilities around the world don't have reliable electricity, forcing health workers to work in darkness or not to be able to use tools that are reliant on electricity. The World Health Organization estimates that as many as 3/4 of the facilities in sub-Saharan Africa have energy interruptions, and a full 25% don't have any electricity at all. And that results in suboptimal care. It's really almost impossible to have high quality care when you can't see what you're doing. It also results in doing necessary procedures and often in cancellations of things like surgeries that can't be done in darkness. It also increases the risk of infection and makes things like trying to maintain personal protective equipment and maintain infection control nearly impossible when you can't really see what you're doing. And this results in emotional burdens both for health workers and patients. Health workers tell us how discouraged that they are to be working in conditions like this, how fearful they are to be working at night. And it also increases a financial burden to both patients and health workers that are now asked to bring in candles or kerosene lanterns or batteries for flashlights. And for especially impoverished families, the idea that they have to now pay for kerosene or batteries or candles can make the difference between someone deciding to stay at home or to come to a health facility for deliveries. We just had our 10-year anniversary on Sunday. WeCare Solar is a nonprofit organization that for a decade has been trying to save lives in childbirth using simple solar solutions. And many of you may be familiar with the WeCare Solar suitcase, which is now in its 3rd iteration. It is a compact, rugged, reliable solar electric system that has been designed specifically for maternal newborn care. It has medical quality lights that are good enough to do C-sections with. It has DC charging for cell phones, for headlamps that come with the solar suitcase. It also comes with a fetal Doppler to be able to monitor babies during labor. A battery recharger and batteries that are used for fetal Doppler. And now you can see in the left corner, we've now added in a thermometer, an infrared thermometer, so that health workers can be assessing temperature easily. Our approach is not just to focus on technology, but also the entire ecosystem around installing and maintaining solar electric systems. So we work in partnership with organizations that are local NGOs, international NGOs, UN agencies, and ministries of health to actually create trainings that build local capacity in solar installation operation and in maintenance. And we also focus on training women to be our solar ambassadors and to lead our training programs. We launched something called the Light Every Birth Initiative 2 years ago, which is an initiative to ensure that every health center, every public health center within a country has reliable electricity and lighting for safe deliveries. And the focus countries that we've initially chosen are Liberia, Sierra Leone, Uganda, and Zimbabwe. When the solar suitcase is installed, we're able to see that health workers are now able to conduct procedures like they would, during normal lighting hours. There's improved quality of care. There's no longer delays. We can do C-sections through the night. Health workers tell us that their morale is improved. We see greater retention of health workers. And we also see increased utilization of health facilities, so that in every country that we've studied this, we see that more mothers are coming in for care. And that's particularly important, I think, during COVID-19. So as far as our response specifically to COVID-19, health ministries have actually asked us to accelerate our programs, because they're seeing that health workers now, in addition to fearing general working at night, they're really fearful of trying to work for patients that might be at risk for COVID-19 in near darkness. So we've been trying to actually seek funding to more rapidly reach health facilities in the countries that are our priority countries. And we're also trying to respond to other countries that are reaching out, asking for our services. And I've also mentioned already that we're including these infrared thermometers that have rechargeable batteries as another one of the appliances we include. We also have been getting requests from governments to try and support isolation and quarantine centers that are set up in locales where they cannot conduct social distancing. So these might be community centers or schools that are now being converted into temporary health facilities, so that local health workers can be keeping people who may be at risk for COVID-19 away from families where they can't have isolation or social distancing, and use these as triage centers. And you can also imagine here the importance of light and also having thermometers for these centers. We've instituted protocols to try and maintain good health for our solar installers, as well as to try and prevent transmission of infection from one health facility to another. So there's a series of those that I won't go into in terms of because of our time right now. And finally, we're really trying to build a rapid response inventory. So we've been actually seeking repayable loans so that we can build up an inventory of hundreds of solar suitcases. Right now, we have about 200 in Uganda and 200 in Zimbabwe, and we're trying to ship out hundreds more in the next couple of months. And I personally have been trying to do a lot of work around advocating for the importance of reliable electricity as part of the PPE. In fact, I think one of the ministerial officials who spoke to me from Zimbabwe said that absolutely light is part of PPE. So I'll just remind that to people here. I've put up my contact information above, but I'd be really happy to talk to anyone here who's interested in a partnership to try and increase the ability of health workers to have the tools that they need, including reliable light and electricity, as part of their fight against COVID. And as far as maintaining and not slipping away from gains that we've had in maternal health care throughout Africa. Thank you.
Thank you so much, Laura, for sharing that story with us, and certainly we will put your contact information up on the listserv for everybody to follow up. We're over time now, so I don't think we're going to be able to take questions from the audience for our innovators, so I apologize for that. But thank you again to our panelists, and thank you again to our innovators for presenting. And thanks for joining us. We'll see you in 2 weeks for our next one. We have not picked our topic yet, but we would love to hear from you on what you'd like to see next on these presentations. These presentations are for you guys to learn from each other and find out what's going on in the community. So thanks again, and we'll see you in a few weeks.